Guys, welcome back. This is the third video. Today I'm going to talk a little bit about hospitalization rates, also talking about the update on Georgia's testing as of today. Going to touch very briefly, and what I hope to do later on is go into this a little bit more in depth, but talk a little bit about potential for vaccine as well as the antivirals. So I know if you watched the conference today, there's a lot of talk about antiviral treatments that might be utilized, and I'll briefly touch on that. Hopefully I'll be able to get more in depth. The more I answer some of these general questions first, I'll hopefully be able to get into some of the literature and a little bit more of the kind of science of it once we get to that point. And then I also will end talking a little bit about the differences within coronaviruses. So we know about SARS, MERS, and obviously now is what everybody calls COVID-19 is actually SARS-CoV-2. And just briefly talk about the differences between them, because I know there was some confusion. What is this, are these different strains and how much mutation is happening as well within these strains? So I'll very briefly talk a little bit about coronaviruses in general and kind of the taxonomy there. So first, I'll start with the current results of positives here in Georgia. So as of today, the update was that there were 287 cases with 10 deaths, which is about a 3.5% mortality rate. And we're now getting data on commercial tests that have been coming back, as well as the Georgia Public Health Lab. So in total, since they've now gotten approval and started testing, the commercial labs have accounted for 1,323 tests, which have resulted in 174 of the positives that we have here in Georgia. Similarly, in total, in all of their testing, the Georgia Public Health Lab has completed 508 tests, and they have attributed 113 of those have been positives. So we're thankfully getting, these commercial labs are actually increasing their capacity, and we're going to hopefully be able to ramp up even more. So that's really good news. I really wanted to talk a little bit about kind of the data that came out yesterday from CDC, a little bit about the cases that have been here in the United States. So it's always good to get data from some of these other countries, but if we can look in real time what we're seeing here in the United States, that helps us understand what's going on. And notably, there's a really large increase, and kind of what people I think are unaware is that almost 50% of those that are hospitalized right now are those who are in that 18 to 59 age range. And I think 20% of the hospitalizations are also, so 1 in 5 of the people that are hospitalized are in the age range of 18 to 49. So this is a group that I know previously everybody was kind of saying was you should be fairly, you should be okay after you get this, and people who are healthy and young, it'll feel nothing more than like a common cold or a flu virus. So clearly there is hospitalization that is happening. Now, I'm not saying in this case that the most severe cases aren't still very much skewing to those who are over 80, over 70, as well as some very significant mortality rates. So we're seeing mortality rates in those above 80 at 15%, 70 to 79 at about 8%. These numbers will continue to change as we get more data, but still very much the most severe cases. And when we're talking about ICUs and people on ventilators, that's going to be those above 60. But I think what I really want to emphasize here today is that we have, almost half of our hospitalized cases right now here in the United States are people in that 20 to 49 age group. So think about that as you continue to practice social distancing, and also understand that these still might very much be people who have more underlying conditions. That data isn't really available to us at this point. I think we'll get more data again that'll help us. I know there's been talk about pregnancy being an underlying condition, and so far there's no evidence showing that being pregnant increases your risk for severe disease. So that's a good sign. But these are things that the more data we get and the more testing we'll be able to do, we'll be able to understand, are pregnant women getting sick but not having severe disease? That's important, and could lead us to understanding the virus and the immune response related to it as well. I really want to touch on the antiviral and vaccine because I think it's important to talk about what's being talked about daily in these teleconferences or these briefings from the White House and what you might be hearing on a day-to-day basis. So The president talked a lot about antiviral treatments, and I actually think that in this case, this might be something that actually is going to be a good idea to really push for. And I'll explain for why I think that is. And of course, data has not been shown in a lot of cases, so we really need to continue to evaluate this. But one part of this is that when we're looking at immune response, so I know that I was doing a little bit of reading, and basically there's been studies done on the MERS coronavirus, which is a slightly different coronavirus, so it can't necessarily be extrapolated to this. But what they're seeing is that in the cases of natural infection with MERS coronavirus, that there was a very good increase in neutralization antibodies after infection. So your body did generate a good immune response, and it was capable of neutralizing the virus. However, what they found in these naturally infected people is that over time, and fairly quickly at that, some of these immune responses began to wane, so we did not have protective neutralization. In some cases, this happened in a matter of months, and they said in almost most cases within a year, there was really no sustained immune response. So this means that if we're going to get a vaccine to this, we have to do something to generate a better immune response, and we also have to do something, so that might include an adjuvant or something that kind of boosts the immune system. And so that information is kind of TBD. So we do know there are protective antibodies, but it doesn't necessarily mean we're going to be long lasting. So if you're sitting there thinking a vaccine is going to be our cure-all, it's not necessarily the case. And as you all know, that's about a year away at best at this point. So I do agree that these antivirals, if they can show they can reduce disease or help limit infection, that's great. And especially talking about some of these that are currently being used on compassionate use, the Gilead drug is one of those that I know they've been administering with use, and I do know it's a little bit of a process to get that compassionate use right now. Maybe that will change. On average, it seems to be taking about 72 hours to go from a physician who reaches out to Gilead to get it. Maybe with the president's directive, we'll be able to get a little bit more ongoing establishment of these antivirals. But I think antivirals might be important, especially in this next year until we have vaccines. And it might be important just to kind of begin to, and I know in other countries, there's sometimes prophylactic use. So basically giving a lot of people a drug. So if we can find something that's very potent and can really stunt this virus for a little while, that might be an alternative too, to kind of really get our hands around this and try to get ahead of this. And hopefully we can kind of reduce disease spread. And maybe these antivirals, if they're effective, and again, that's a big if at this point, if they're really effective or can reduce disease, that might be a really good way to help our healthcare system stay less burdened, as well as maybe prophylactically give to very high risk people if they're in an area that's sustained outbreaks. So these are all things that we can implement, and I do feel like this is a good move, and I do appreciate that. I feel like the administration right now is taking that seriously and thinking about other ways around this, because social distancing will work, but this is going to be a long time, and until we have vaccines or effective ability to prevent this is going to be going on for quite some time. So keeping that in mind, I wanted to just briefly talk about coronaviruses, and I'm going to keep this brief, but I know there was some kind of confusion what this is. So Corona in general there's so many different genuses within the Coronaviridae family, and we've got things like and I'll talk about the beta-coronaviruses, you have alpha-coronaviruses as well. And so if you look at them, there's a ton, and there's ones that are very specific to animals, a lot of bat coronaviruses, as we know. But I want to talk about the ones that we all know in human infection, and there are coronaviruses that do circulate that don't have significant pathology. So there are other strains of coronaviruses. Notably, I think there's some beta coronaviruses and some coviruses that are human that are not really as significant. But we all know about SARS and MERS, and so both SARS and MERS are under the genus of beta coronavirus, but there's subgenus within that. And in the case of MERS, there's the MERB covirus, and that's the subgenus within beta coviruses or coronaviruses. And within SARS, is a beta coronavirus, but its subgenus now is the SARS-CoV-virus. And our current COVID-19, which is actually what the disease is, it's not the strain, I'm sorry, not the strain is, it's also a SARS-CoV virus, so it's similar to SARS. So what actually, when you look at the taxonomy of this, is SARS essentially is SARS-CoV, and that's the one we refer to as SARS. However, the coronavirus that's circulating now is actually called SARS-CoV-2. So it's very similar to SARS-CoV in that they're genetically more similar, and they fall within the same genus and subgenus, but they're going to be slightly different strains. And there are, like I said, there's a number of other coronaviruses, and so if you looked at all of them, you would be overwhelmed with the amount of them. But what is important to know is that coronaviruses, unlike, for example, influenza, don't really have the capacity to change their antigen, so the protein on the surface of the cell that your body might recognize or a vaccine might recognize. So when people are talking about mutations and things like that, really, it's hard to say how much it can be tolerated within coronaviruses. They're a much larger virus than influenza, and they work a little bit differently. So what we're not seeing is significant mutation, but you're always going to see some, change over time. But if it will disrupt in terms of the protective ability, that really hasn't been seen. There's not as much kind of, as we call it, antigenic changes that disrupt that. So that's a good sign. But we really don't know how much it can tolerate. I guess in total, I'll look into the mutation rates a little bit more and see if we can understand that. But it's not as error prone as influenza just due to the nature of the polymerase. We're now talking about a positive sense virus as opposed to negative sense. So that makes some changes in the genome and its ability to kind of not only accidentally, so error-prone polymerases mean they kind of accidentally add mutations. That doesn't happen quite at the frequency it does in, say, influenza viruses. What you need to understand is that there's so many different coronaviruses. Some cause things like common colds, and some cause much more severe acute, disease, such as the example of SARS. Very briefly, SARS was I think it was 2004, and it was about 8,100 cases and had about just under a 10% fatality rate overall, and that only really got to 17 different countries. So we're already talking about something that has kind of a high mortality rate, but it's widespread at this point. MERS was a little bit different. MERS had about 2,000 cases in total and a 36% mortality rate. However, MERS didn't spread quite like SARS did, and it was a little bit more easily contained, and there seemed to be a little bit more like healthcare situation dependent. So within hospitals, there would be outbreaks and things like that. So it had a dramatic lower spread. I do want to note that in the case of SARS, we talk about R naught as a way of kind of understanding the ability of the virus to continue to infect. And really what you want to see is the lower the R naught, the better. And what I think the best way to explain R naught is if you have an R naught of 1, that means if one person gets infected, on average, they will infect one other person. And R naught of 2 means that one person gets infected, and on average, they'll infect 2 people. So when we're talking about SARS and when we're talking about this coronavirus that's currently circulating, so SARS-CoV-2, we're talking about R naughts that are higher. So they're in the maybe 2.5 to 3 range in the case of this current one. But what I want to note is SARS also had a high R naught value. Similarly, the SARS we talk about is 2004 outbreak. That had a similar high R naught value. With social distancing, that R naught dropped down to 0.4. So that means that if we can control this, contain it as much as possible, we can significantly reduce the amount of ongoing infections. That's how important social distancing is. Now, if you have an R naught of 0.4, that means on average, less than one person is getting infected when each person gets infected. So you've now reversed it. You get an R naught below 1 and you're in a good place. You're now ahead of the virus. So more people are not getting infected than getting infected on average in exposure situations. So continue to socially distance yourself. It's very important in the next 2 weeks. Let's see if we can really turn the corner on this. I think that's about it for today. I'm going to try and keep going through stuff and try to keep it relevant to what you're hearing about today, and also answer the questions that I continue to kind of trickle in. And then, like I said, hopefully I'll get to some publications and a little bit more of the real data that's happening. So have a good day, continue to distance, continue to wash your hands, stay safe, and try to tackle some of your projects that you've been meaning to get around to that you've put off. So with that, I'll see you next time.